I'd like to welcome everybody to the 16th Annual Endocrinology and Metabolism Board Review. This is a conference that's sponsored by the American Association of Clinical Endocrinology, the American College of Endocrinology, and the Cleveland Clinic. We are pleased this year to have everybody come. And if you are taking your boards, we certainly hope that this is going to be a good experience for you and that you have that this will make your experience taking the boards a lot easier.
You're now 8.5 hours into your course. I either admire your tenacity or you're very afraid of your upcoming exam, one of the two. So please put your seatbelts on. I'm going to run through some cases fairly quickly. I'm going to describe them as they really happened. Nothing has been whitewashed at all. So the first case is a 43-year-old gentleman, 20-year history of hypertension, worsening over the past several years, now poorly controlled on 3 medications, moderately overweight. Somebody cleverly ordered a renal artery ultrasound that was entirely normal. We've already heard about doing that on the first fishing expedition. Let's look at some of the labs. He's hypokalemic. This is going to be a review of some of what you already know. Serum aldosterone was within the reference range, but up towards the higher end. And as you are all world experts now, the plasma renin activity was lowish. And 24-hour urine aldosterone was elevated. Cortisol looked okay. Ordered some metanephrine, and they were fine. No problems there. He had a report of a CT scan that described a normal right adrenal and described on the left side as a just over 1 centimeter mass. The Hounsfield unit density is very, very low, -100, and their interpretation is that this was a myelolipoma. And of course, we never believe the report. We always have to look with our own eyes. When you're given a report that says there's a left abnormality, your eye should always study the right adrenal first to make sure you're not being bamboozled with a bilateral disease. And this looked absolutely fine to me. And if you scan down another couple cuts, this adrenal is starting to look a little plump, and you can hallucinate a little bit of nodularity here. So the next step in the management of this patient, are we going to repeat some adrenal serum studies off of the blood pressure medications, add aldactone, do adrenal venous sampling, or just waltz in there and take out the left adrenal? You guys were paying attention. Very nice. And some of you didn't even believe the workup. Okay. So we jumped to adrenal venous sampling in this patient. Let me walk you through this, because this will bring out some of the points that you were previously